Good morning, everyone. I'm Olga Petryna, and I'm reporting from the ACR meeting in San Diego. This morning, I had the pleasure of moderating a great session where Dr. Mankat presented data on cardiovascular comorbidities in inflammatory and autoimmune conditions. Dr. Mankat is a cardiologist at the Mayo Clinic, and she also runs a center for cardiovascular women's health. And in this session, she emphasized on the importance of screening patients with autoimmune and inflammatory conditions for cardiovascular comorbidities. Apparently, patients with inflammatory conditions such as rheumatoid arthritis, lupus, ankylosing spondylitis are all at a higher risk of both structural and functional cardiovascular disease. And such complications as valvular dysfunction, pericarditis, and pericardial effusions, as well as cardiovascular ischemic disease, are very common. For unknown to us reason, in lupus patients, inflammatory markers don't tend to correlate with the risk of cardiovascular disease. And in a lot of RA patients, Framingham risk scores are not really reliable. And there is no known reason for that. It is known that patients who are treated with biologic DMARDs have better cardiovascular outcomes and lesser risk of cardiovascular disease as opposed to non-biologic DMARD therapy. Long-term chronic steroid use is a negative factor increasing the risk of cardiovascular disease again. And interestingly enough, use of statins tends to attenuate this long-term steroid effect. All in all, it was suggested that patients with rheumatoid arthritis, lupus, and other autoimmune conditions be screened for underlying cardiovascular disease, even if they don't have obvious and severe manifestations of the disease or signs suggestive of active disease, as early treatment and prevention may have an important role in their outcomes. And oftentimes joint cardiology and rheumatology clinics are a great idea for this type of screening. Thank you. If you would like to know more, please follow us on roomnow.com and have a nice day.